Let's talk about acute myeloid leukemia, or AML. Now, you probably know it's the most common acute leukemia in adults, and because of that, it's a diagnosis you really need to have on your radar. So in this explainer, we're going to cut through all the noise and give you a super high-yield clinical review. It's going to be perfect for your day-to-day practice and, of course, for your board exams. Let's get right into it.
First things first, before we really dive in, I want to give a huge shout out to Dr. Mohammed Al-Naji Mohammed. The entire foundation for this review comes from his excellent and really thorough work. We've just distilled those key insights for you today.
So here's our game plan. We'll kick things off with the absolute basics of AML. Then we'll get into what it actually looks like in a patient, the clinical features. From there, we'll cover the really critical prognostic factors that help guide treatment. We'll also put a special spotlight on APL, which is a subtype you have to know, and we'll wrap up with the latest WHO classification, which is really changing how we approach the disease.
All right, let's get started with Section 1, the basics. So, what exactly are we talking about when we say a patient has AML?
Okay, so at its very core, what is AML? I want you to think of your bone marrow as this incredibly busy factory that produces all your blood cells. In AML, that factory gets completely hijacked by these faulty, immature myeloid cells. We call them blasts. And these blasts, they just multiply like crazy, completely out of control, crowding out all the normal assembly lines for healthy red cells, white cells, and platelets. This shutdown of the factory, that's what causes every single clinical problem we're about to see.
You know, clinically, it's really helpful to remember that AML can show up in two main ways. It can be de novo, which basically means it just pops up out of the blue in someone who was previously healthy. Or it can be secondary, meaning it actually evolved from a pre-existing bone marrow problem, something like myelodysplastic syndrome. And that secondary type, well, it often comes with a tougher prognosis.
Okay, so we've got this picture of total chaos happening in the bone marrow factory. Now let's see how that chaos actually translates to the patient who's sitting right in front of you. That brings us to Section 2, the clinical features. Just remember, every single symptom we're about to talk about is a direct consequence of that factory failure.
So this is the million-dollar question, right? What does this actually look like in the clinic? What are you going to see? Well, the signs are all tied to that classic triad of bone marrow failure.
And this slide just lays it out perfectly. It all comes down to this triad of problems. So first, you're not making enough red blood cells. That leads to anemia, which is why patients look pale and complain of just crushing fatigue. Then, you're not making functional neutrophils. That's neutropenia, and that leaves the patient wide open to getting really severe or recurrent infections. And finally, you're not making enough platelets. That's thrombocytopenia, and that's what causes the easy bruising, the little petechia, and sometimes serious bleeding.
Now, beyond that classic triad, you've got to be on the lookout for a couple of other common findings. A lot of patients will complain about this deep, aching bone pain, especially in their sternum or long bones. And that makes sense, right? It's the physical pressure of the marrow just being stuffed to the brim with all those leukemic blasts. And when you do your physical exam, you might also feel an enlarged spleen, or splenomegaly, because it's been infiltrated by these abnormal cells.
Okay, Section 3. So once you suspect AML, the very next supercritical step is figuring out just how aggressive this particular patient's disease is. And we do that by looking at prognostic factors. And trust me, this isn't just an academic exercise. This directly tells us who needs more intensive therapy and who might do okay with less.
This slide really highlights some of the key red flags that tell you this is a high-risk case. Some are pretty clinical, right? Like being older or not responding to that first round of chemo. But more and more, the most powerful predictors are actually genetic. Things like adverse cytogenetics, deletions on chromosomes 5 or 7, for example, tell you there's a lot of instability in the genome. A complex karyotype, that just means genetic chaos. And then you have specific mutations, like FLT3-ITD, which basically acts like a gas pedal stuck to the floor, just driving those leukemic cells to grow relentlessly.
And I really want to pause on this one for a second. Age over 60. It is one of the single most powerful and consistent predictors of a poor outcome. And it's not just about being frail. It's that older patients often have a more complex, chemo-resistant disease to begin with, and frankly, they have fewer physiological reserves to handle the really tough therapy we need to throw at it.
All right, let's switch gears and put a spotlight on a very, very special subtype, acute promyelocytic leukemia, or APL. You absolutely 100% need to know this one, both for your exams and for your practice. Why? Because it's a true medical emergency, but it's also one of medicine's biggest success stories. This table is basically your cheat sheet for APL,
everything you need is right here. The genetic hallmark is that classic T15-17 translocation. What that does is create this messed up fusion gene called PML-RAR alpha. And that faulty protein is what freezes the promyelocytes in their immature state. Under the microscope, you're hunting for our rods, and clinically, the immediate life-threatening danger is DIC, disseminated intravascular coagulation, which can cause catastrophic bleeding.
So what in the world are our rods? Well, they're these really distinctive, needle-like rods that you can see inside the cytoplasm of the leukemic cells. They're basically just clumps of granular material, and if you want to see them really well, you use a myeloperoxidase stain. When you see these, you should be screaming AML, and specifically, you should be thinking APL.
And this is the beautiful paradox of APL. It presents as this terrifying medical emergency, but it's now one of the most curable forms of leukemia we have. And the reason is targeted therapy. This drug, all-trans retinoic acid, or ATRA, it essentially goes in and overrides that faulty PML-RAR alpha signal, and that allows the arrested blast to finally grow up and differentiate. It's really a landmark case of precision medicine at its best.
You know, all this talk about genetics is the perfect segue into our final section, the modern WHO classification. The update in 2022 represents a massive shift in how we even think about AML. We've really moved away from just looking at cells under a microscope to defining the disease by its specific genetic driver.
Just look at the hierarchy on this slide. Genetics comes first, period. The diagnosis is now led by identifying these specific, recurrent genetic problems, like the T15-17 in APL, or by defining it based on key mutations like NPM1 or TP53. The way the cells look, the morphology, it's still important, but it's not the main definer of the disease anymore. In today's world, the genetic identity is king.
And this all brings us to our final thought. As we get better and better at understanding the exact genetic drivers of AML, the classification system itself is becoming a roadmap for treatment. The question is no longer just what is it, but how will this specific, gene-defined subtype reshape our entire therapeutic approach for this one individual patient? The future isn't just coming, it's here, and it is truly personalized medicine.